So signs and symptoms by the artery. So your American Heart Association has an acronym to help patients remember, or just people in general, to remember the symptoms of stroke, and it's FAST. So face, arm, speech, and time. So face is facial droop, arm is arm weakness, speech is slurred or jumbled up speech, and then T is for time, and that means time to call 911. There are other acronyms too, like FASTER, or they've come up with all different kinds of things, but I think the American Heart Association has kept with FAST. Some of the immediate symptoms that you're gonna look for is the numbness, confusion, trouble seeing, trouble walking, or a severe headache. So any of these arteries that can be impacted would be those main arteries, like your anterior cerebral, middle cerebral, posterior cerebral arteries. Then you've got the smaller branches, like those communicating branches, the capillary network. So, capillaries are at the end, so all the way at the end of the vessel. And then you have arteriovenous formations. And so you can have what we call arteriovenous malformations. And that's kind of when you see strokes happen in pediatrics a lot of times. It's when there is a AVM, is what it's called. And we'll talk about it in a little bit. So, your vertebral and basilar artery stroke. So this is it accounts for 20% of the ischemic strokes that happen in your brainstem and your cerebellar regions. So this is talking about dissection. Do y'all know what dissection would mean of an artery? It busts, basically. The dissection of an artery would mean that it opens. So that would be pain, usually in the posterior neck, or I can't say that, and spreading to the shoulders. So that's different from what is ischemia, okay, which is what we've been talking about, right? With just a traditional embolic stroke. You would see gait and limb ataxia. So remember we talked about uncoordinated movement is what the cerebellum, or coordinated movement is what the cerebellum is responsible for, right? So if we hit the arteries that supply the cerebellum, we're going to impact the ability to have coordinated movement. And uncoordinated movement is called ataxia. So you're gonna have cerebellar ataxia. You could have limb weakness, oculomotor palsies. So what do you think that's from in the brainstem? We're getting that nucleus of your cranial nerve, your oculomotor nerve, right? And then oropharyngeal dysfunction. Oropharyngeal, yeah, so that's with swallowing, difficulty swallowing. And that's because of where it's at, right? Where all our cranial nerves are. So we get those cranial nuclei that are responsible for swallowing, that can have a dysfunction. So you see now how this has built, right? What we talked about before is now building to what dysfunction looks like. So if you know what the area does, then you obviously can figure out what the dysfunction is going to be. So function is related to dysfunction.
Is there like a level of like severity per se? Because
Sure.
like
Yes,
so far it's like if it hits this part of the brain, like all of
the above could happen,
Could
right?
happen, yeah.
But sometimes not all of the above happens. Yeah. Absolutely, you're correct. So sometimes it may be one or two things from that, or it could just be one. So any of the above. So if you had a patient, let's say, with this issue, if they had ataxic gait patterns, right? So I know from talking to Kim that Dr. Leatherman has talked to y'all about ataxia and tried to show you what it is. I've got a good video of it later for y'all to watch too. But what do you think, like intervention wise, you could do to impact and help this patient that has ataxic movement?
teaching them something like aerobic, or some kind of like stabilization, or because they have no
So how would you stabilize? That's good. Your brain's going there. How do you stabilize?
strength.
Okay, that's a good thought. What are some other ways?
Teaching balance, flexibility.
So balance training, right? I can buy that.
Awareness. Cause like even if you uncoordinated, you can be aware of like what's around you. So it don't be like, I don't know.
What about adding weight when they're walking? We can add ankle weights, we can add weighted vests when they walk. That's one of the common things that we can do to help patients with ataxia. Now, we also have to consider, right, if we just have ataxia, that's okay, but if we also have limb weakness, we don't wanna load somebody's legs down with a bunch of weight either. So tactile input, you give them feedback, right? You help them correct.
You work on weight shifts at that point?
There you go, good. Good. What about like oculomotor palsy? So what happens in that sense? Like if somebody has that problem, what are you gonna be mindful of when you're trying to help them?
I gotta be able to focus on something.
Like it would be, what's the word?
Nystagmus?
Yeah.
Okay, so they may have nystagmus, right? So what would you be concerned with? Yeah, cause they're not getting good input visually, so it can impact their balance. What else? Mhm. Yeah, like focus, right? To attend to what you're doing and scan the environment for safety. So like when they're ambulating, they're not able to control their muscles in their eye, right? So when they're scanning the environment, they're getting distorted pictures of what it is, right? So that can impact their ability to use assistive devices safely, to ambulate safely, to transfer safely, right?
Can it move into like the waist?
Yeah.
Can it move into like the waist?
Not with this, we'll get to that. Does that kind of make sense to everybody? What that could look like for a patient? And then the bottom here, oral pharyngeal dysfunction, you don't really deal with this, speech language pathologist is gonna deal with this. But what you do need to be very mindful of with these patients is if they have a swallowing impairment, they may be on a thickened liquid, or they may be on a modified diet plan, okay? When you get to facilities later on, they're gonna tell you more about those diets. They may make you, try some of the liquid. It's kinda like swallowing snot, if you ask me. but like puree diets. So basically, you need to be aware of the policies and procedures in place in the facility that you're in order to not risk aspiration with your patient, okay? And aspiration is not always those signs and symptoms like with the tearful eyes, the postnasal drip, the hoarse sounding voice. They don't always present with that. Sometimes we can have silent aspiration where we don't see the signs and symptoms of it, but it's there. So you just always need to be mindful of that because that puts your patient at risk of pneumonia. So at our facility, for example, we have a wristband that they wear that'll tell you what their diet is. It'll tell if it's mildly thick, if they're on a puree diet. So then you're able to know, well, I don't need to give this person thin liquids. It needs to be, thickener needs to be put in it for them to drink it safely, okay? So those things for you are important because we still want to promote hydration and nutrition with these patients, right? So hydration is important. So if you have a patient down in the gym and they're thirsty, you need to be able to provide that for them and provide it safely. So being aware of this would allow you to do that. So in your chart review, this is something you need to look for with your stroke patients. Is do they have swallowing deficits? And if they do, then what is their diet? Okay? Does that make sense?
Is that just to have them like train that, like trying to get that function back, or is it?
They will with speech language pathology.
Like
That is their.
The main reason, or could they just be on an IV with that?
That doesn't sustain life for very long. So you can be on intravenous nutrition, which is it's okay. Typically, if they're on that very short term, and then they're gonna get a peg placement. So then they get the peg and they're fed through the peg, but still, even with peg nutrition, it's not the same as eating food. So the goal is always, number one, safety, right? I'm telling y'all about safety. Number one, safety, but secondly, is to get them the best nutrition that they can get. And then, I'll figure out the word in a minute, in like 5 minutes when I'm not thinking about it. But yes, the goal is for speech language pathology is to progress these patients to where they don't need that to eat. But if you notice that that's an issue, right, with you, and you notice that they were dropped from speech, like speech is no longer seeing them, or speech is not evaluated, you would want to recommend to your physical therapist, hey, I really think this patient would benefit from speech therapy. So you can also recommend services if they're not receiving them for referrals. And there's a lot of things that they can do to assess swallowing. So there's a thing called a FEES, and so where they send a light and a video camera up their nose and down, and they watch them swallow different materials or different textures, and they see what they aspirate on, and that's how they put them on a specific diet plan. And then there's barium swallow studies where they give them an actual barium, and then they go and do a study to see if they're aspirating as the barium goes down their digestive tract. So, in acute care, you're going to see a barium done quite often because it's the most readily available thing, and they have the technology to do it. If you're in like inpatient rehab or a skilled nursing facility, you're going to see them use FEES quite often. And if you ask me what FEES stands for, I have no idea. I'd have to look it up and tell you because that's not in the forefront of my brain. But it's FEES. Okay. So this is specifically with cerebellar infarcts. You're gonna have the dizziness or vertigo, inability to sit upright without support, without holding them. Difficulty walking, you may have some nausea, vomiting from the dizziness or the vertigo. dysarthria. Why would you think you'd have some dysarthria? Do you remember what dysarthria is? Poor articulation, right? So why do you think that would be the case if it's impacting, if it's in the cerebellum? Speech is affected, right? So your tongue is a muscle, right? And it takes coordinated movements to have good articulation, right? So when we have uncoordinated movement patterns that impact our tongue, then we have poor articulation. Okay? Or headache. All of these could have headache with them. Okay. This is the really sad one, guys. If you have complete occlusion of the basal artery, it causes death. And that's the result of hitting those brainstem nuclei, your cranial nerve nuclei, and it's because they control vital function for your body. Partial occlusions can cause tetraplegia. That means what? Tetra means 4, right? So all 4 limbs are impacted. You have the loss of sensation. Their cranial nerves can be impaired, obviously, and then they could be in a coma. And severe partial occlusion of the basilar artery can cause what we call locked-in syndrome. And that is when this patient can only move their eyes. And when I mean locked in, they are cognizantly aware. They are intact cognitively. They cannot move anything but their eyes and their body. And so they communicate with eye gaze, typically. And they're dependent care patients. It's very sad. I've had one. He was upon stroke. It's actually one of my very good therapy friends' grandfather that had this syndrome.
Can they come out of that?
No. I've never seen it.
Is this usually, like, does this happen from trauma?
Just for the same reasons that we were talking about before. Occlusion is, what would be occluding the artery? Cause if it's your basilar artery, we have to think, it's not gonna, unless there's a huge clot that's stopping it, right, that's blocking it. Cause your basilar artery is a little bit larger than your other vessels. We gotta think that could be from a thrombus, right? I mean, you could throw a large enough clot from your heart to occlude it, obviously, because the vessels in your heart are much larger than your head. Okay. So, anterior cerebral artery is this little bitty portion right here. Okay? So you can think of it, it's gonna be on both sides. So it can impact your personality and cognitive changes, because remember I said this is gonna be where? Typically, frontal, right? So it can impact your personality and cognitive, contralateral hemiplegia and hemisensory loss of fine touch sensation. Y'all see how MCA strokes are huge? Look at this. Look how big this is. Can you imagine which one's most commonly impacted? It's your MCA. Okay. When I say MCA, I mean middle cerebral artery stroke. So this, when it affects the cortical branches, it deprives the optic, radiation, and lateral parts of the sensory motor cortex and adjacent white matter of blood. Oh, with blood. Not other. So it causes contralateral homonymous hemianopsia. That's not spelled correctly. I'm gonna talk about that in a little bit. Causes hemiplegia and hemisensory loss. The hemiplegia affects mostly the face and upper limb more so than the lower limb, and this is very, very true. If this is one of the textbook things that I could take away, this right here would be it. Because you know in the clinic, everything doesn't appear like a textbook says it does, right? This is one of the things that appears like the textbook says it will. They may have language or spatial understanding deficits, depending on which hemisphere is affected. So where is your Broca and Wernicke's area? What side? What lobe? On this side. Huh?
Right?
No, not lobe, sorry. Which side of the brain? Do you know? Left. There you go. Perfect. It's on the left. And homonymous hemianopsia is visual. It's a visual disorder. I've got a good picture down here at the very bottom of this slide, and I'll talk a little bit about it when I get to that, okay? I don't know what happened here. I'm sorry. So if a stroke affects language, it's usually in the left hemisphere, like Sam says. And of course it's called aphasia. So if the frontal can impact Broca's area, what do you think MCA is going to impact? Wernicke's, right? So receptive aphasia. But it also can impact your spatial relationships. It will cause neglect. And when I say neglect, I mean they're going to neglect that side. There's a little bit of difference in that. From right to left side of your brain. So if your right side is impacted, then you're going to have left neglect, okay? That means you are completely neglecting that side. If the left side of your brain is impacted, you are going to have right inattention. You cannot attend to that side. Which one do you think is easier to help? Inattention. Neglect has poor prognosis with therapy. Want me to say that again? Okay. So if you have the right side of your brain impacted, you are going to have left neglect. if the left side of your brain is impacted, you are going to have right and attention. Neglect has a poor prognosis, even with therapy. Poorer prognosis than inattention. So then they're gonna have problems with spatial relationships that cause apraxia. So there's a difference between a taxic movement and a praxic movement, okay? I have a video later on that too, that's helpful. I think it's in different, I don't know if I put it in this one or in the I think I put it in this one. So when you think of a taxic movement, you're gonna think of your cerebellum and you're gonna think of uncoordinated movement patterns. When you think of a praxic movement, we think of the ability to plan movement, right? So Jazz, when you said they have a hard time getting started, they have a hard time initiating movement, that is a praxic. Because they don't know where to start. So a lot of times they need tactile cues to get them started, or they need a visual cue to get them started. How do you think you can provide visual cues to a patient?
Pointing somewhere in
The mirror?
Putting them in front of the mirror, right? That is the ultimate visual feedback for a patient.
So, when you say that, do you do that more one-on-one, so as to not overload?
Yeah, so it depends on where they are in their recovery process, right? But if we're thinking about they're pretty soon out of a stroke, they need a lot of visual feedback in order to correct posture, right? So a lot of times if we've got this heavy MCA stroke, they've got hemiplegia, like that side ain't doing nothing. And if they are neglectful of it as well, so if we're thinking it's left, it's a dent, we call it dent stroke. They're very heavy on the upper extremity. You'll see the lower extremity will return faster, especially because we walk on our legs and we weight bear through our legs. We do not weight bear through our arms, right? So when we talk about recovery of arms, OTs really do a lot more of that, but it's harder for us because with MCA strokes, your upper extremity is more impacted, because remember that homunculus that I gave y'all? That's the part of the homunculus that's hit, right? Is that arm. And that arm is a lot of times poor prognosis with MCA dents, MCA left neglect strokes, just poor prognosis. As far as recovery of the arm, the leg sometimes will come along. And that's because you are continually weight bearing through your leg. And when you're doing sit to stands with a patient, when you're doing weight shifting with a patient, like all of those things, you are giving proprioceptive feedback to joints constantly in therapy when you're doing those things. But I literally have to put somebody on a mat and make them weight bear through their arm constantly and through their elbow constantly. And it's a lot more, you have to be a lot more intentional with doing it. It's not intuitive to just put weight through your arm, right? So we go back to what I told her about, like, why do you think proprioceptive feedback is important? Like, why do you think weight bearing is important? To increase the sense of self, right? Like to know where your body is in space. So like you can't correct posture if you don't know where your joints are. So the first thing you need to be thinking about too is like, how do I do that? Like, how am I gonna do that with a patient that can't even sit up? So how would you do that if your patient can't sit at all?
Put some weight on it.
How would you facilitate proprioceptive feedback if your patient can't sit upright?
They learn their feet.
What?
Think about developmental progression. Developmental progression. What would you do? Start from the bottom, right?
So could they like push on top?
Sitting, like just weight bearing between your ischial tuberosities, right? So weight shifting and sitting, right, from side to side. We're bearing weight through both of our booties, both sides of our booty. And we're getting proprioceptive feedback to the trunk. So when we get trunk control, then what can we start trying to do, Miles?
Tickle their feet.
Then we can work on standing, right? Right? So that we have to follow that developmental progression of like what's appropriate at that time for the patient. What are the deficits? What do we see as the problem? If they can't sit upright, that's the biggest issue. Before you can stand, when we did the steps to sit to stand, what are the steps? Tell me somebody, please, what are the steps to sit to stand?
Put a gate gun on her. And you're gonna explain to the patient what you're gonna do.
Love you, Jazz. Just keep going, please.
Sit to stand. Grab the gate gun, sit and squat yourself, and then
No, them. If you are doing a sit to stand, what are the steps to do a sit to stand?
like me as
Scoot out to the edge, right?
Am I using my arms?
Sit under just unsupported. No, just a step to a sit to stand.
Well, if you got some legs, not legs, arms on the chair, you can push your chair stand up.
And you push this chair and you stand up, right? So the first step to doing a sit to stand is sitting off the back of the chair and scooting your butt forward. So if your patient can't sit up, what is something you're gonna do? Work on sitting up first. Then you work on weight shifting. Then you work on scooting. Then you work on what? Leaning nose over toes, right? You see how we're now taking every single piece of that and we're breaking it down and we are working on every single piece of it in order to facilitate movement. Does that make sense? Okay. So middle cerebral artery, stroke, deep branches. That supply the striatum, the genu, and the posterior limb of the internal capsule. It causes contralateral hemiplegia and it affects the upper and lower limbs and the face equally. What's the difference between hemiplegia and hemiparesis? What is hemiplegia? Okay, your PCA, your posterior cerebral artery.
I have a question.
Yeah.
Okay, we like compare with like the ACA, ECA, and then PCA stuff.
Uh-huh.
Okay, I understand that like it depends on like we said, every part could get affected, but just not every thing. But like,
Yeah.
which again, it still depends on the patient, but which one is more likely for them to like be more functional than?
A little bit. I
Like,
think to be more
is
functional.
one more severe than the other? Like ACAs are like
MCAs are very severe.
those
A
are
lot
like
of
most
times.
severe. But between like ACA and PCA, then like is one more severe than the other?
Not in my experience. PCA is more visual impacted. So I wouldn't say that it doesn't impact their quality of life. And there can be some coordinated movement issues with that as well. But if I had to get a stroke, I probably want it in my PCA.
That sounds good, but I get what you're saying.
Isn't it? It's a super strange thing to say.
Do the patients know what they get, what they have, or does the doctor just tell them they have a stroke?
Yeah, they wouldn't tell them they have a stroke. Doctors are very bad at telling people what's wrong with them. So I do a lot of condition education with patients, like a ton. Because a lot of times they don't get that education and they basically put it off on us, on other people, nurses, us, whoever. And honestly, to their defense, they are very busy people and they do have lots of patients to see and lots of things to do. So they don't necessarily have time to sit down and speak for 30 minutes with a patient on their condition. But at our facility, we have certain educational materials to give to patients. So like we have a whole stroke book. So like, and it's like a chapter book, it's a big book. So we, a lot of times if they can't read it, we'll give it to the caregivers so that they can understand what's wrong with their loved one. And we also do like a family education prior to discharge, to get them used to moving the patient however they move, or those things. And home health is good for that too, because you're in the environment that they're in, and you can help modify the environment to increase their function. So all of the different, and actually home health has some really good handouts. A couple of the places that I've met liaisons from different home health services, and they've actually brought us some of their literature and their books that they give patients, and they're very good resources for patients. So there's a good bit of education that is given to them. Now, do they always read it? No. But it is helpful for them to read it to know what's wrong with them. And if you can give them a good understanding of what's going on. I will give you the spiel that I normally give a patient that's had a stroke. So most people know what I-85 is in this area because it's a rather large highway. So what I tell them a lot of times is your brain has been used to going down I-85 to get to Atlanta. And what has happened is there has been a traffic block in Peachtree City, and you gotta find a back road to get there. And I'm helping you find that back road with therapy. So I'm rerouting those neural circuits in order to get the function that we need. So, thank you. So, that is normally how I explain it to a patient. The other, oh wait, I didn't even talk about this. Okay. So, a stroke affecting the midbrain, I don't even like all of this.
Just kidding.
How about this? Just know what deficits can be had with this stroke. Don't know like the branches, like the flow, the blood flow. So know that they could have blindness from the contralateral visual field. So people with PCA can have what we call is a field cut. So when you see when we talk about a field cut, so let's say this patient is looking this way, okay guys? So this is their right side, and this is their left side. So if they've had a right-sided stroke in their PCA, okay? So on their right side, the visual fields that are going to be impacted so they can't see this way. Oh, maybe done that backwards. So it's gonna be on this side, sorry guys. Eyes confuse me too.
So it's still affecting the opposite side, but it's just affecting the opposite side of the eye.
Yes,
Like half of the eye.
half, yes,
But what's the opposite side?
yes. So basically right here. But I do that because like it's how you see with your, in your nasal line.
So it's the right side of both eyes, is what you're saying?
What's the left side of both eyes?
Yeah, left side of both eyes.
What's this called?
A visual field cut.
Does this stroke affect, peripherals, like peripheral vision? Cause I had a patient Friday at clinicals who had a stroke, and it caused him to lose his peripherals. Like, he has no peripheral vision.
Yeah, it can impact that.
Since this is the one that affects like the eyes.
Yeah,
In the book, it has a little chart too, and I was looking at it, on page 341 for the posterior cerebral. It says lack of interest in movement.
Not just that.
do you see over here where cerebral area supplied, where it's got temporal lobe there? When they say lack of interest in it, it just means that they just don't feel like doing it, they don't wanna do
It's like impulse control
it.
still.
Not impulse control,
What?
behavior,
Right,
like
but I mean,
depressive
like,
mood.
I might need to do something, but I don't want to, so I'm not going to do it.
Yes.
Okay.
That's a good little chart. Okay. So just know the impacts of this, yes.
So if you lose your peripheral vision, like Jasmine was saying, what side of the brain is affected, or is it both?
Both.
Okay.
This left side is. Cause this is. I'm looking at this, yeah, this is the same left side.
It's harder to know without knowing exactly which part of his brain is impacted, because he could have had both PCAs impacted and then a part of his MCA distribution impacted as well. That it could more so impact his left side. Is that what you're saying?
Yeah, cause he did everything for reviews, but like, when we got him up to law, his left foot would pronate so bad, so like, the PT was telling him,
He
cause I
has
was.
an extensor synergy pattern.
It was looking at this bad. But yeah, he couldn't, he was walking hard, and like, his left foot would pronate so bad. And then he started sticking his left arm to stick on his left side.
I need a break. Okay, go.
Yeah.